All right. And welcome back, guys, to the Self-Selecting Podcast. Thank you. Thank you for being here. Thank you for tuning in. As always, whether you coming from Spotify, Apple Podcast, do me a favor. Leave me some kind of review, some kind of feedback. There are a lot of new people. I mean, like every time I go to look at the analytics for any of the platforms, YouTube included, as if you are coming from YouTube, like, comment, subscribe. I am seeing day to day there's a lot of you showing up, a lot of new subs, new viewers. But I'll say that despite that, there are not nearly as many reviews, as many comments, as many there for the number of new people that are tuning into this. I want to hear from you guys. I want to hear, do you like what you're listening to? Do you like what you're seeing? Do you like the topics that we're covering? A lot of new people, I'm thinking, just due to having different guests on the show, sitting down, having different conversations. Recently had Alex Bush, had Justin Mahaly, got Eric Bagheera coming back. If you missed that first episode and you're late to the party, you're catching him on the second episode, which I'm sure will be out before this episode. Go back. I mean, like, I know I said it on that episode, but if those are topics that you're interested in, training for hypertrophy, more specifically, training to build glute growth. Yeah, I would go back and listen to the first episode as well. That dude is just such a weapon. Anyways, today, not being joined with anyone. I will be joined with two different people later this afternoon, but this morning, is going to be recording day for me. Just me, just solo podcast, which I appreciate those of you who have reached out and been like, I like the guest, they're nice, enjoying the conversations, but I don't want you to stop doing the solo podcast. Please come back on. Those messages are very, very appreciated. So thank you. If you're not already, you're wanting the short form content, you can see there are medium clips. If you're just like, hey, I need it in snippets, it's too much, it's too long, I can't get through all of it, that's fine. We post the medium clips, the short-ish form, a few times a week on YouTube. So if you are from Apple, from Spotify, and you're like, I like the long podcast, I do, but sometimes I need the chunks. I need it batched in a more digestible manner. Then go ahead, head over to YouTube and subscribe. Anyways, we are going to get rolling today. It's going to be a little more of a technical video, I would say, compared to compared to the abstract videos that, I mean, like, frankly, I think a lot of us can derive like good takeaways from, like, related to food behavior, related to adherence, pitfalls in dieting, in building muscle. These are all things that, like, sure, it's nice to understand the theory, but like actually having the application of how to troubleshoot these common problems, that is a large majority of the content that I put out, is specifically with long form content, as you probably know if you are not a new listener. But this video, this is going to be a little more technical, which I know some of you have requested. You've personally been like, hey, I want to learn. I want to know more about these disease processes, about these drugs that you either specifically talk about or allude to. So today we are talking about something that I think a lot of people, they got questions around, and that is PCOS. So Polycystic Ovarian Syndrome. And this is kind of impromptu. The last Q&A I put up on Patreon, someone that is struggling with PCOS, interested in using PEDs, kind of wants to understand, like, okay, down the line, is this something that I need to worry about relative to fertility? And I don't get a ton of clients with PCOS. It does happen every now and again, but this is always something that, I mean, I just have to be honest, like, the symptoms, the treatment, I mean, I shouldn't really say treatment, the interventions, the recommendations, these are given 100% based on the individual's presenting symptoms. And in, like, just being clear here, like, anything I say here in today's episode, I mean, like, sure, you might be able to pull nuggets from it. You might be able to, reverse engineer it and make sense of maybe something you're going through or someone you know is going through. But I want to be extra clear. None of this should be taken as medical advice. It's not medical advice. I'm just sharing information with you, sharing information on social media. So please take it for what it is. Take it with a grain of salt. Take it for entertainment purposes, if you will. So when we look actually into the name PCOS, so poly meaning multiple, cyst meaning follicles, oftentimes people associate this kind of disease process, this diagnosis, with cyst on the ovaries, and it's not the case 100% of the time. This can happen. Yes, there are individuals who actually do have cyst developing on their ovaries, and this can occur from multiple follicles that are not reaching ovulation, or it can be a transient occurrence where it's just like one single isolated instance. But there are really three methods in which we can classify, we can categorize, associate these characteristics with PCOS, and that's androgen excess, ovarian dysfunction, ovulatory disruption, or insulin resistance. Now, oftentimes the question I get is, how do I know if I have PCOS? Like, how would I even garner whether or not to be suspicious of this kind of diagnosis? And the reality is, this is something that some would say, okay, it's overdiagnosed, because just given these qualifications, if we were going to use like the Rotterdam criteria, which is really the gold standard, it's how PCOS is diagnosed, you only need 2 of these 3 markers. So you could have someone who is experiencing androgen excess as well as insulin resistance, and technically they would be meeting the criteria of being diagnosed with PCOS. And I think that's oftentimes the case in the world of like physique sports and fitness. Is at least in my sample, I get a lot of individuals who are coming to me who are suspicious that they're experiencing PCOS. Yet when I start to ask questions about like their PED use, more specifically the use of anabolics, it becomes very clear that, not clear to me because this is something I know, but it becomes very clear really to the individual. Oh, these signs of androgenicity, these signs of hirsutism, acne, changes in vocal pitch, in voice. These are things that are overlapping from someone who uses anabolics in excess for long durations, as well as PCOS. And typically, if I look, at like I'm always looking at their intake form, but if on their intake form, if they're like, yeah, you know what, I have been running Anavar for an extensive amount of time throughout last season, and I just still have it in because I don't really know when to pull it. But at the same time, I'm not sure why I'm experiencing these signs that what appear to be like, having researched it a little bit, having seen, others in similar positions, it seems like it might be PCOS. Typically, my first line of intervention is like, hey, or let's just call it a recommendation or suggestion, if you will, grain of salt. I think that's what I want to categorize it as. First thing I'm going to want to do is say like, hey, let's come off the drugs and see if these signs of androgen excess, if those are still present. Now, the other case in which I see, at least the individuals that come to me who suspect they have PCOS, or, inherently are worried, worried about some kind of hormonal imbalance that lends to issues in weight loss, insulin resistance, and, some form of amenorrhea, whether that be hypothalamic amenorrhea, or, I would say like exogenous based amenorrhea rooted from an exogenous catalyst. Let's just call it that. Those individuals who are not already using some kind of AAS typically have an extensive history of using some kind of hormonal birth control. Now, in this case, it's not my place to be like, hey, just like stop your birth control. But for individuals who are suspicious of, maybe the birth control itself is having a negative impact, on the current physique or on their physique goals, that's typically something I would like to see them do. I would like to see them make efforts towards not having the hormonal birth control in place. And it's not to say they have to go off birth control entirely. It's just a matter of finding a type of birth control that better suits their needs of, why are they having the birth control in to begin with, that doesn't have a negative impact on their physique goals, on their body composition. So I think the thing to understand with PCOS is that in some cases there are it's mostly androgen dominance, and some are mostly insulin resistance in terms of the presenting symptoms. And I mean, you can also attest that there are genetic components to this, and really that's where it becomes difficult to receive an accurate diagnosis. I'm someone myself, I've had low test for majority of my life. It just varying degrees of insulin resistance, but I mean, also, you can look at family history as opposed to lifestyle. And I've been in and out of contest prep at various points in the last decade-ish, last 8 years. Yeah, that would make sense. That would add up. Yet at different points, I've gone to doctors, some who have, I guess, singular, one who's been oh, I think you have PCOS. I'm I disagree. On what criteria are you using to diagnose this? Oh, well, you're amenorrheic, so we should screen you for PCOS. Okay, well, my androgens are very low and I'm not insulin resistant. Still think I have PCOS? Oh, you do? Okay. The thing is, when it comes to female endocrinology, when it comes to, really seeking clarity around what the underlying problem is, I get it. There are a lot of doctors who are going to turn to what they're taught, and of course they should. They should rely on their formal education to come to these diagnoses. But I think it can be problematic in the case where you have standards in which we're making these diagnoses that are not clear cut and leave room for ambiguity. Now, I think one of the reasons that individuals are commonly diagnosed with PCOS, even despite the baseline symptom of androgen excess, is there is a demand within the medical community, or really, I would say, an imbalance in doctors wanting to treat these kind of, diagnosis system disorders holistically and address the root cause, as opposed to just putting someone on a medication. And I think right now, I'll admit, I am one of these people. There are a lot of platforms that, they really do, they demonize birth control and give the appearance that in general, okay, birth control should never be used. And this is one of those areas that I can say, I have a ton of content out there where I'm directly speaking to individuals who should not use birth control. And I stand by that. I think using it inappropriately not only will have deleterious effects on your physique goals, but long-term, putting it in place to correct irregularities in your cycle that potentially are linked to a very modifiable lifestyle factor. I think that's inappropriate. Yet, I see this time and time again with my clientele. Individuals will come to me who were put on birth control, whether they had the suspicion of PCOS or not, due to the primary chief complaint of irregularities in their cycle, many of which also get that secondary diagnosis. Okay, you're menorrheic, but you're also potentially experiencing PCOS. I think a lot of times putting that birth control in place, you're actually covering up and masking some of the really important signs and the clues that could help correct whatever kind of diagnosis you might actually be experiencing. Which ultimately, I think, if you break down these symptoms, you can see, which I'm going to go through this with you, the symptoms, they're really tied together on a spectrum versus the magnitude at which someone is experiencing each specific symptom. But This is largely related to either hyperestrogenism or an imbalance in both estrogens and or androgens with the rest of your hormones. So when we look at, okay, like what are the actual symptoms? Okay, ovarian dysfunction, this state of oligo-ovulation or anovulation, or, just having an ultrasound with polycystic ovaries. The term like anovulation, it's usually defined as less than 9 periods a year, or an interval of more than 35 days in between menstrual periods. And this in itself, I guess, so that's like oligomenorrhea, that and ovulation are not synonymous, but this is something that we need to take a closer look at. And specifically for the physique athlete, for an individual who is going through these states where you're hyper restricted, you're in these states of low energy availability, I would say like anytime we're assessing these symptoms, we have to assess them in contrast to the state that you're in that could be exacerbating these symptoms. So your ovarian function, is that something that at this point, even outside of a contest prep, you struggle with? Did you struggle with irregular periods, having a irregular cycle, or very intense, very unfavorable symptoms associated with your period prior to starting contest prep? And there's certainly methods in which we can gain insight into where you are in your cycle, even if you're having irregular periods, if you're unable to, accurately time your lab work to assess, okay, where are these serum levels at a given point in the month? Like common methods to track, one would be like cervical mucus monitoring, which yes, that is going to be fairly difficult to learn. You could certainly do it under the right supervision. And a lot of places like related to fertility, they're going to hopefully at least guide you in how to do this. You can also take basal body temperature, which yes, we're looking at a very narrow range, and that can be challenging in itself, depending on how consistent you are in your day-to-day life. So if you're someone who, is not on a regular kind of sleep-wake cycle, if you're someone who is in any way like immunocompromised, if your diet's kind of all over the place, if recovery is suboptimal, all of these can have impacts on that basal body temperature upon waking. But ideally, in a pretty controlled setting, we should see about a 0.5 degree increase in your waking temperature, so your temperature in the morning. This is taking your temperature first thing in the morning before you get out of bed, and we should see that increase right around the release of progesterone, as progesterone is thermogenic, so in the later half of your cycle. You can also test progesterone. So in the luteal phase, like kind of at the end of the cycle, you can test for an LH spike. And this is something that can be done at home. And sometimes it's spiked for up to 12 hours. So just having some other metrics in place to at least map out your cycle, or map out relatively when you're in each specific phase, or when you're experiencing these rises and falls of certain hormones. I think that can be helpful, at least in gathering, okay, is this something that is tied to my current lifestyle? Is it tied to simply being in contest prep? Ideally, I mean, just the same way that we would argue, okay, you can't really time and track your periods as accurately as you'd like when you're in a recovery state, so post show. I don't think that you're going to gather a lot of valuable information trying to dissect and make sense of what your specific cycle looks like during a contest prep. And it might seem counterintuitive. There's probably people listening who are like, wait, if I'm trying to preserve ovulation, because Corey, that's what you said is the epitome to of female health is making sure you're ovulating. Why wouldn't I want to monitor these things during a prep? I mean, frankly, you can, and sure, there's an argument kind of that you should, but I guess from my perspective, it's we know during this time irregularity is expected. Irregularity in your cycle, irregularity in your hormones, and particularly even more so if you're an athlete who's getting as lean as you need to for the first time, if you're including any kind of anabolic androgenic steroid. These are all things that are going to affect that HPO, that HPA cascade. And frankly, I would try and treat any kind of underlying disease process, in this case, PCOS, that would be something that we would want to really unveil in a state where things are not as volatile, which contest prep, things are expected to change. They're expected to be dysregulated. So as I'm saying that, I'm like, oh, I hope that makes sense. Let me know if that does make sense. I'm not convinced it does. Also, going back to FSH, LH, this might be an instance, like if you are having the irregular periods, again, outside of contest prep, outside of post show, this is like strictly in a healthy, like your baseline. This is like the best you feel, the healthiest you believe you are. Checking LH and FSH, as we do see that LH and FSH, the ratio of 2-to-1 or 3-to-1, that usually is what we see is presenting in individuals with PCOS, just because the overproduction of LH, that tends to result in the cyst formation, the androgen increase. Now, what other symptoms are we looking for? Insulin resistance. So again, like tying this back to contest prep. Okay, well, we can track blood glucose values fasted, but an actual diagnosis is required. So having a fasting insulin of over 6.0, there's an index that, like, yes, we can take a closer look at, but looking at fasting glucose versus fasting insulin level, that would be helpful. And I personally find that, like, in a state of contest prep, even though like body weight is down, and like technically we would think that this in itself is going to sensitize us to insulin, so reduce that fasting blood glucose. It's not always the case. And I do find that, like, if we're talking about an individual, not like a transformation individual who's losing a ton of weight, but an individual who's, maybe losing 10, 15, maybe even 20 pounds isn't a ton of weight for that individual. In the case where you're losing weight, but you're also driving up fatigue at the same time, and potentially stress is increasing as you make your way through prep, which is very expected at this point. If you're including things that do inherently cause an increase in insulin resistance. So using something like GH, even at very low doses, that shift that we're looking at, that insulin sensitivity, that might not be what we would predict in a contest prep, given that we have these other variables that are impacting blood glucose. So again, like tying this back to when we're assessing these symptoms, we have to be really clear on what external variables or what environment we're in that could ultimately be creating these symptoms from inception, or exacerbating very mild symptoms that still could have another underlying cause. Also on that, like the insulin glucose challenge test, so blood tests following 2 hours after you have like the hyperconcentrated just drink. So that's something that, like, if you've gone through pregnancy, they typically will do that pretty early on, just to see, okay, what are whether or not there's risk for gestational diabetes. Now, A1C, I think that can be helpful, again, like contextually though. If you're someone who was in your like post-show, like the first 3 months, and we're capturing that to make up your A1C, okay, well, this might be something that ultimately is a little skewed. And depending on how structured you've been with your diet and really just your food intake as a whole, depending on how quickly you gained weight, this could certainly give you a value that is heavily skewed in favor of a diagnosis of, let's say, PCOS without the right if the right context is also not provided, which with the classification of like androgen excess, this is one that ultimately is going to be very individualized, as it would be with any kind of AAS use. This is something that a lot of individuals, they can go a long time without ever really like pausing and thinking, okay, well, could it be the drugs in place that are causing this? I see this a lot where individuals, they will associate those symptoms of excess androgens, and frankly associate that with an underlying disease process, and sure, that it could make sense to dig a little deeper and see, okay, was this present prior to the inclusion of AAS? But it's not to say that this is just something that you have to write off. Like, if you prior to the use of AAS were experiencing symptoms of facial hair growth, darker hair growth, acne, androgenic alopecia. And I mean, like, obviously I want to confirm this with lab work, because for some individuals who, let's say, have not maximized their circulating endogenous androgens naturally, simply having the presentation of hirsutism, acne, alopecia, like having those symptoms as a baseline, even if their circulating test is on the lower end, this is going to be really important in us making decisions around how high we actually push their TRT or supportive therapy, whether that be actual test or DHEA. Now, this in combination with an individual who, let's say, is on birth control, we have to consider that someone with PCOS, like in theory, like the textbook, they should present with a lower SHBG, theoretically a higher free test. But if someone is using a synthetic form of estradiol, progesterone, this can have impacts to invert really those values. So coming off the birth control, and certainly something that you might still see, which we actually, I'm gonna cover that here in the next section with 4 types of PCOS, which I think you guys are gonna like. But just when we look at androgen excess, we have to look at what is the individual's baseline of experiencing these symptoms. Have they not exacerbated these symptoms with the use of an exogenous hormone or medication? And realistically, if they're going to include something down the road that could exacerbate these symptoms, what is the risk acceptance that they're willing to tolerate? So I think like being really clear in terms of what their threshold is, for hair growth, for acne, really the vocal changes and clitoral growth, clitoral megaly, those are not things that we typically see with individuals within the bell curve of PCOS. I mean, most women with PCOS, their values of circulating androgens, they're not really in the 200-300s. I mean, I'll tell you, the sample size I've seen, which sure, some might say, okay, it's not that big. I've had 2 people that have been over 60 nanograms per deciliter. And I mean, they say okay, there are these unicorns that exist who are over into that super physiological level of circulating endogenous androgens. And I'm sure they exist. I mean, I'm sure there are a ton of people who just don't get the lab work pulled, period. But I think that's where we have to look at total circulating test relative to free test and consider, okay, what is the ratio or the threshold for that individual who's experiencing unwanted symptoms of PCOS? What is that threshold, and what are the consequences if we continue to raise that total circulating test? So I think when we get into the 4 types, which this is going to be one that there is a lot of overlap within the realm of categorizing the different types of PCOS. And we have insulin resistance, but outside of that, we have post-pill, so coming off some kind of hormonal birth control. We've got inflammatory PCOS, we've got adrenal PCOS, and some questions to think about with the insulin resistant type of PCOS. We really need to have that objective, that quantitative data. So we need the proof of actual insulin resistance. And like I said before, this is something that I would really work hard to distinguish whether or not this is caused by some aspect of what you're doing during prep, whether intentional or unintentional, and particularly post-show. But if you're finding that that insulin resistance, I mean, over 100 for that fasting glucose, a human RI of over 1.5, or you're seeing in an insulin glucose challenge test, those levels are out of range. Those are all indications that could potentially be something that that type of PCOS is the type you're experiencing, as opposed to looking at the other types. When you look at something like a post-pill driven PCOS, really the question here is, were your periods normal before starting birth control? You should meet the criteria of having PCOS while having normal menstrual cycle function before getting on the pill. So that's what can be tricky, is if you have an individual who, let's say, has been on birth control for decades. I mean, like maybe in some cases since they were pubescent, like they started the pill sometime in that 13, 14, 15 year range in adolescence. And if that's the case, I mean, like that individual was really never set up to go through a normal menstrual cycle. I mean, from the get-go and from the jump, they were having a modulator in place to suppress some of that function. But in the case of someone getting on the pill, let's say in adulthood, like they're trying it, we do see post-pill PCOS strongly associated with Yasmin. That's not one that I've used, so I can't attest to that, but Yasmin users, Yasmin previous users, if you want to drop your opinion or your experience in the comments below, that would be appreciated. I can say that like being on the pill for a very short time comparatively compared to other individuals who've been on it like decades, I felt those symptoms. I don't have PCOS, but just being on the pill, period. That was something that, I mean, like the changes in hormonal function, like the suppression of certain hormones, and really I guess like the suppression of hormones that were already suppressed, that wasn't as extreme as like experiencing the suppression of, let's say, hormones that were at a baseline. So estrogen, that's one that being on the pill, even for a couple months, like very acutely, I felt those changes, and I was not a fan. And that's a large reason why, like in my case, I do find that a non-hormonal form is my preferred method of birth control. So in my case, that would be the copper IUD. I don't think that this is going to be the answer for everyone, but I do think for the individuals who are really looking to minimize the impact of I guess the hormonal impact from a source of contraception, copper IUD, I've had a great experience with it. I'll just leave it at that. Third type, inflammatory PCOS. I think it's also important to understand like symptoms of high inflammation can be very abstract, and they can be transient, they can be localized. So this might present as like digestive issues, unexplained fatigue, headaches, joint pain, psoriasis, eczema. What up? It's me. This is one that could be exacerbated, certainly in a contest prep, given like your intake, your micronutrient intake specifically, is likely going to be reduced, just given your total food volume will be reduced. But being in that state of high inflammation, whether it be due to deficiencies in the diet or just perhaps your individual resilience as to whether or not you're handling the state of being at that body fat, being under, being, I guess, privy to a very high degree of fatigue for sustained periods of time and being under recovered, that can definitely exacerbate those symptoms. So last one being the adrenal PCOS. So this is typically comes from one or three places specific to the androgen excess. We're either seeing an overproduction of testosterone from the ovaries. Not always the case for individuals in contest prep, as the state of contest prep will actually suppress those functions. Androstenedione, I know I'm mispronouncing that because I usually just say the abbreviation. I don't have it written down, from the ovaries or adrenal glands. Okay, so that's going to be further up the chain, or DHEA from the adrenal glands. That androgen excess, though, when we're looking at the contrast between total circulating test as opposed to the bioavailable test, looking at what medications, what supplements are having negative impacts and in turn raising SHBG as opposed to lowering it. This is also something that we could reverse engineer and say, okay, well, for the individual who does have a higher or just say a moderate circulating test, but their SHBG is high and we've removed any kind of catalyst to that we're aware of. Okay, what can we do to continue lowering that SHBG, thereby raising free test to capitalize on that circulating test? In the case of someone with adrenal PCOS, we don't really need to worry about that. I would also consider ruling out other possible causes. So if you're seeing that elevated prolactin, or even like non-classic congenital adrenal dysplasia. Both are driven by abnormal stress responses disrupting the HPA axis. So even though adrenal fatigue is something that is very difficult to diagnose, and I believe, if I understand correct, feel free, argue with me in the comments below. It's not something that we have a firm set method in which it's diagnosed, and in many professionals and educators, educated individuals, much more educated than me, have gone to bat to argue that it is something that it should be more specific if we're going to categorize it as a true disorder, as a true underlying disease process. The abnormal stress response is a real thing. To what extent can you recover from it? Our bodies are very resilient, and I think that ultimately is going to depend on your baseline and whether or not you are in a position to recover from the degree of dysfunction that you incur. Now, when we dig a little deeper into your decision tree of okay, I think I have PCOS, but I don't know how to determine which kind. I'll walk you through that. First thing you're going to do is look at lab work. So if you don't have lab work and you receive that diagnosis, that's something I would question. I would just question, why was lab work not pooled? Why are we going off of exclusively qualitative data to make a diagnosis that we could confirm with lab work? So does lab work show high androgen and irregular periods? If it doesn't, okay, it's not PCOS. Next, do you have insulin resistance? And this is something, like I said, it needs to be confirmed. So you need to have either high fasting, the IR over 1.5, or insulin glucose challenge test. So one or several. I would opt for several just because these are not difficult tests to run to confirm that diagnosis. Now, let's say you don't. Let's say you're in that second stage of, okay, I don't know if it's insulin resistant, but do all these tests, or at least come back with the high fasting, which is probably the easiest one to pull from. Okay, high fasting or your fasting is not high. Cool. Then we can go to, did you have regular periods before hormonal birth control? So two types of characters here. You have the individual who, no, they did not have regular periods prior to, because they were put on birth control at a very young age. This might take a deeper dive in terms of troubleshooting what the culprit could be. But yes, if you had regular periods prior to birth control, that could very much be the post-pill PCOS. And this would be just regular periods. How are we categorizing this? You've had 8 or more periods a year and you were ovulating. So recall that I have said this, if you're just having the bleed, yes, that is good. We want to see you have that period. That's preliminary, but that in itself doesn't mean that you're ovulating. We really want to confirm that with lab work. So in the case of someone who is going through a state of contest prep, and maybe religiously, once you get under this body fat or this body weight, that's when you experience that in ovulation. That's when you start missing periods. Okay, well, we need to capture whether or not outside of that state of contest prep, are you having, several periods back to back very consistently? And ideally, in the case of a physique athlete or someone who is potentially going to be entering contest prep again, I would like to encompass those full 8 or 9 periods. I'd like to have lab work at least on the first half of those to confirm that we're seeing that rise and fall in estradiol and progesterone, because if we're not seeing that, that could be still a state of anovulation or sub fertility, if you want to call it that, really for that individual who has previously had cycles that were irregular. I'm going to be more the probability of me wanting labs to support that they're ovulating is greater, so we can pinpoint what interventions have been fruitful, have moved us in the right directions, and what potential catalysts have caused us to take steps back. So in the case for the individual, okay, I didn't have regular periods before hormonal birth control, so you were irregular, started a hormonal birth control, cool. Well, we know that's not post-pill PCOS. Then we go to the next question. Do you have signs of chronic inflammation? So these symptoms, they can seem very baseline, and they can see in a contest prep like unexplained fatigue. Well, I wouldn't consider it unexplained fatigue. We're talking about the individual who they're managing their recovery. They're in a non-fat loss phase. So like if you were in a state of if you're in a catabolic state, if you're in a deficit and you're someone who, inherently you struggle with that metabolic flexibility of reaching new levels of low body fat, okay, well, like that fatigue, those headaches, like those might be things that we could, in some ways associate with just being in a state of lower recovery. But for the individual who is not in that state, who they're not post-show, who we can reasonably assume is able to recover, they're not overtraining, they're not on a very dysregulated sleep-wake cycle. Presenting with these symptoms is certainly something that we need to take a closer look at. Lastly, is DHEA the only high androgen? So in this case, okay, you have low test, you have low free test, but we're seeing that high DHEA. Okay, we could very much allude that maybe this is adrenal PCOS. So, okay, when we start looking at interventions, I mean, this really is going to come down to what symptom we're trying to correct. So it's something like insulin-resistant PCOS. Now, conventionally, this is addressed with birth control and metformin. But it's important to remember that birth control, it can actually worsen insulin resistance. So in my opinion, I mean, like just putting it in place blindly as a solution, I think we're looking at best at net zeroing those symptoms. Realistically, metformin and birth control, I don't think that much is going to be done. And I think there could be symptoms that potentially were not present resulting from the inclusion of birth control, depending on the individual's sensitivity to those fluctuations in hormones. I think realistically, going about it in a manner that rather addresses dietary interventions and whether or not the individual has the ability to modify their lifestyle, their caloric intake. I mean, universally, exercise, it's a great insulin sensitizer. And if you take someone who previously, I mean, like they've been at a BMI that is problematic and puts them at risk for the development of type 2 diabetes, I would say in combination with something like metformin or any kind of anti-hyperglycemic, this could be beneficial under the guise that they're going to do something to reduce their BMI. So when you look at something like metformin, I mean, like, yes, it's going to be helpful, and I would say it's like the most prescribed medication on account that it's going to decrease blood glucose, improve insulin sensitivity, decrease the action of insulin on the liver. But in terms of tolerance and whether or not this is the best fit for every individual, it's really going to depend on their sensitivity to the drugs. I mean, yes, pharmacodynamically, the effects are going to be very positive, and there are even some effects that suggest that it can work on the gut microbiome. So that in itself could improve symptoms that weren't as prevalent, I guess considered even more mild. But when we look past that for the individual that, maybe doesn't have access to metformin, which in this case with diagnosis, that shouldn't be a problem. Alternatives would be something like Berberine. However, we do have to consider the sourcing and quality control associated with Berberine. Some people, they find that they do better on Berberine as opposed to metformin. Others find that Berberine causes a little more GI distress. So again, like, are we correcting a symptom only to create a new one? If they're able to tolerate metformin, that might be a better route to go. When we look past that, I mean, there is a lot of data for things like myo-inositol, acetylcysteine. They tend to improve fertility rates with individuals with PCOS phenotype, but this is largely just tied to reducing oxidative stress, which is probably higher in someone with PCOS. So collectively, if that's the drug that we're using to attack oxidative stress, what I would like to see are other measures also being other avenues also being hammered. So things like reducing your sugar intake, especially through more processed sources that elevate hunger signaling, avoiding extreme caloric deficits for cravings. And I mean, this is something that if the individual is already on a very like micronutrient dense diet, then we have to ask, okay, is the quantity impractical? Is like the volume of food they're eating or the calories that they're eating, is that impractical in a sense that now this is causing these very acute overages that are ultimately leading to unwanted fat gain. Also just training, performing cardio, and this like largely is tied to the nutrient partitioning benefits that are associated with that. I think when we start getting into just like baseline supplements that would help with insulin resistance driven PCOS, I mean, you can look at something like magnesium. It's used for several processes throughout the body, but specifically with insulin sensitivity, that would be magnesium biglycinate. You also look at vitamin D, which again, ovarian follicle maturation, which I mean, like in the case of someone who is experiencing amenorrhea or that ovarian dysfunction, I mean, we can certainly say that just as a baseline, regardless of the type of PCOS, this is something that we should be paying attention to, and we should be monitoring whether or not we're seeing those improvements. In contest prep, sure, but largely outside of contest prep in those non-fat loss phase states. Now, when we start looking at post-pill PCOS, the things that you need to remember is that this is temporary and it's going to take some time to resolve. So again, this is under the criteria that you had a regular period before starting the pill. Big things here: avoiding dieting, avoiding going into contest prep, because you really can't avoid amenorrhea when you're someone who's like kind of on the cusp of being adequately resilient enough. If you're aiming to achieve new low levels of body fat or extending, I guess, like spreading yourself so thin in very long duration contest preps, these are things that can exacerbate or push us back into states of amenorrhea. Moving past that though, like when we look at supplementation, really the supplementation that's going to be best associated with mitigating some of that ovarian dysfunction. When we look at zinc, I mean, like this is going to have some effects on ovarian function, and oftentimes we do see that there's some kind of zinc deficiency post hormonal birth control. We also see that for individuals, this is kind of related, but I'll segue on that. Individuals with copper IUD, that's something that even like peripherally, they're going to have some kind of higher concentration of circulating copper. So it might be worth supplementing with zinc simultaneously just to ensure that those zinc to copper levels are adequate. Post pill, I mean, like looking at either a form of progesterone support, so that could be micronized bioidentical progesterone, and you would essentially use this to mimic the progesterone elevation from the luteal phase. You can normalize this, normalize that signaling from the hypothalamus to the pituitary, and a step down really from the progesterone would be supplement like a chasteberry or Vitex. And I mean, like, no, you're not going to have the exact same effect just because that is then causing the release of progesterone as opposed to just putting the progesterone in your body itself. So it's a second like stepwise process, which I think could still be beneficial if someone is unable to access the truly like prescription or non-prescription micronized progesterone. When we're looking at someone who is dealing with that androgen excess, I mean, using a natural supplement like licorice, this could be helpful in reducing like your total serum testosterone levels. This is something I would be a little hesitant to include unless truly like your endogenous production of testosterone is excessive. And I mean, if in that case it's aromatizing into estradiol, we could potentially look at modulators to further break down E2 into weaker forms of estrogen. So that'd be something like DIM or calcium glucarate. But the dosing of in any of these that I'm describing is based on the concentration of the formula. And I really, really have a hard time just giving blanket statements on, hey, this is what you should take. So if that's something you want assistance with, if it's something that you are finding like, hey, I do need to modulate the levels of certain hormones as opposed to others, shoot me a message, set up a consult call, set up a one-time consult, and we'll get you going. Okay. And moving down to inflammatory and adrenal PCOS. Inflammatory PCOS, mostly going to be addressed through dietary intervention. So these symptoms, it's going to largely be the IBS, unexplained fatigue, joint pain, eczema, psoriasis, and the first step is really going to be removing the dietary triggers. So if you're on, let's say, a very loose diet that includes a lot of trigger foods, I would start with just a cleanup, just a minor cleanup, moving to more micronutrient dense foods, potentially even whole foods. But then past that, if you're having still a lot of those digestive symptoms, so maybe we're looking at something like FODMAP based food diet. So something that's removing very specific foods, but like wheat, dairy, if we're able to solve those digestive issues, okay, good. That seems like that managed a lot of the bulk of those symptoms. But oftentimes that is not enough. We're also going to need to lower the stimulus of training. So, whether that be actual weightlifting itself or weightlifting and cardio, just bringing total output down, as this is creating that just excessive state of inflammation. So looking at this from a multi-pronged approach, yes, correcting the diet, that's going to be a huge one, but it might not be enough depending on what the rest of your lifestyle looks like and whether or not you are able to increase your recovery. So if your recovery capacity is already maxed out and you're still having these symptoms, this might be something where we do have to turn to training and modify the amount of training days or the training volume that you're currently at. Supplemental suggestions. So we got our acetylcysteine, or NAC, melatonin, zinc, magnesium, already covered both of those, but really anything that is going to help lower that oxidative stress, which, I can tell you that a lot of people, they want to have those supplements, those adaptogens, those things that will help you manage stress better. And I've used them myself, but really the things that are going to move the needle the most, that is going to be the lifestyle modifications. So number one, identifying your stressors. And this is where I really encourage you to be as specific as you can. Categorize them into the stressors that you're able to control as opposed to the ones you're not able to control. Okay, the ones that are modifiable, the ones that you can modify. At that point, I would take all of my remaining energy and put that towards modifying those lifestyle factors. So that can be sleep, that can be interpersonal relationships, that can be, maybe work stress. There are going to be some that I understand, you're not going to have a lot of control over. And if that's the case, yep, you have to look at what other avenues, what other levers you can deploy. But the ones that are going to pay dividends, that are going to allow you to see the most progress the fastest, are going to be the lifestyle modifications. So when we look at adrenal-based PCOS, right now, there's not a conventional treatment for this. Yes, we can consider removing stress from your lifestyle as much as possible. And that's something that, again, a lot of people, they will give me some pushback with that, oh, I can't modify it. It is what it is. But past that, really we're looking at whether or not the individual is experiencing those higher levels of circulating androgens. And if that's the case, okay, maybe putting something that is going supplementally is going to lower that. But I would do that very cautiously. I would definitely do that under the right supervision. So when we look at the PED decision making for individuals with PCOS, you have to understand that the unwanted effects, the androgenic effects, this is the result, it's the product of the androgen binding to the androgen receptor. So women with PCOS, even though with most women, with biologically born women, we have two X chromosomes. Now, one is usually turned on, the other is turned off. But with women with PCOS, this tends to be skewed. When we look at your circulating androgens, you have your testosterone, you have your DHEA, your DHT. Androgens alone, even weak androgens, they can bind and then cause that gene transcription, which then that's where you see that secondary sexual characteristic deepening of the voice, androgenic alopecia, darker facial hair growth, some, prevalence of acne. And in some women, we can address these by changing the sensitivity of the receptor and changing the density of the receptor. But really, after that, if you're trying to prevent these side effects, you want a combination of less synthesis or more metabolism or less binding to the receptor. So really, if you're trying to prevent these side effects, you want some kind of combination that is going to promote less synthesis or more metabolism and less binding to the receptor. And once we start talking about pharmacology that reduces that androgenic, that burden, you really don't want that at the time that you're trying to conceive or you're trying to promote fertility. So example of something like finasteride, dutasteride, these are known teratogens, and you don't want to be taking these because they can cause, particularly in the male fetus, changes to genital development. Now, these are ones that I think a lot of women will kind of put in place or be told, hey, recommended, this is something that I would begin, on account of those androgenic side effects, specifically the hair loss. But what you have to remember is that they do have peripheral effects, and this can present in terms of lower libido or effects on both estradiol and progesterone. Another one that we're looking at is spironolactone, which is commonly given alongside metformin. And there's mixed data to support its efficacy and if there's an alternative or if the benefits actually outweigh the potential risk. So it's one that I personally would say that really any kind of diuretic or adjacent diuretic, they can carry a bit of a side effect because, yes, it's going to modulate blood pressure, but when we look at ones that are potassium sparing, this is going to be something that needs to be closely evaluated, even though, yes, it will offer more of an androgen antagonistic like effect. When we start digging into what this looks like on a day-to-day basis, considering whether or not that effect is beneficial enough to outweigh the risk of now a hyperkalemic state or even the diuresis that is going to accompany regular administration. Now, when we start looking at the hair growth, like terminal hair growth, for example, so on the chin, on the upper lip, there are topical agents, and you can certainly go with a treatment like a laser hair removal. And these things, they can be helpful, yet you have to understand that once the hair has set in, on the jaw or the chin, removing that mechanically or destroying that cell, that's really the best it's going to get. And then past that, it's about promoting a regimen where it's unlikely to reoccur, which usually is the best way to go about it. But in the case of someone who has PCOS, is already sensitive at the receptor site as a whole, who does plan to use any kind of AAS, this is certainly something to consider and not necessarily look at as an indication that you're doing something wrong, but rather this is a consequence of the consistent and repeated exposure to that drug. Yes, the best way that I would recommend going about preventing and mitigating the risk of any of these side effects with or without PCOS is to minimize their exposure and to reduce it only to times that are absolutely necessary. But even with that, I think understanding that no degree of anabolic use is technically going to be risk-free. All of them do carry that same risk on account that just as we take on the hope and the promise of the anabolism, the androgenic effects are as equally likely, even if we're looking at someone who is more sensitive or does have a higher likelihood that they will present with these unwanted effects. As far as different medications, anti-androgens, you're going to see if you go to different providers that they're often just given, but when we look, just given alongside, hopefully the idea would be the encouragement for the athlete to remove any kind of AAS or any kind of hormonal therapy. But I've also seen it at times given alongside hormonal therapy, which I personally think is a little problematic because it's okay, if in this case, I'm talking about a specific instance where the individual, they were not diagnosed PCOS, they struggled with acne previously. They were put on HRT at a starting dose of 20 milligrams. It was injectable. So, I mean, like, it was like the best form at which they could receive the drug, the hormone. But the individual, her circulating serum testosterone levels were very high. Like, they were absolutely super physiological. Yet, instead of bringing the dose down, the provider opted to put in spironolactone on a regular basis. And that was just the play. And I mean, like, it was a young girl. She was a young girl. I mean, it was something that personally I would question, like, is this really the best route of, or sorry, really the best intervention to mitigate those signs of acne? Or would it be favorable to just lower the dose as a whole? So, I hope this was helpful. I hope you guys enjoyed this episode. I hope it wasn't too dry. Let me know what you think in the comments below. As always, like, comment, subscribe, and I will see you in the next one.